This program is a presentation of UCTV for educational and non-commercial use only.
Good evening, everyone. Welcome again to the Mini Medical School in our course Advances in Primary Care. Tonight, I'm going to talk about obesity and diabetes, and I've entitled the talk, What Can We Do with the Twin Epidemics of the 21st Century? I will be discussing a variety of products, predominantly pharmaceutical products, and I have no conflict of interest with any of them. So, most of you know a fair amount about obesity. You practically can't pick up the newspaper or watch the television without hearing something about weight, nutrition, and obesity these days. And so I'm not going to spend a lot of time on what I think you know. I'm going to assume some knowledge and try to focus on the things that have been controversial in the last couple of years and things that we have learned from either recent clinical trials or years of clinical experience here at UCSF and elsewhere. I'm a general internist, primary care doctor, as many of you know, but I also run our weight management program and our interdisciplinary program on diabetes for our residents for many years. And so there is whence my interest in these two subjects begin. A colleague, this is not an original term, the globesity epidemic, but it does try to make the point that this is no longer just an issue in the United States or in the developed world, and I'll show you some data on that in just a moment. But we're now up to about a billion people on the planet, about roughly a third or a quarter or a third or so of the people on the planet who are overweight, and 300 million of them who qualify as truly obese. And I'll define those two terms in just a moment. And we've now reached a point where overnutrition, or overweight and obesity, is more common than undernutrition. So most of us grew up in an era where, clean your plate because there were starving children in blah, blah, blah. And now, even throughout the world, in places where once there were many, many starving children, and still, in fact, are millions of starving individuals with malnutrition, more around the planet actually are overweight. And I'll show you that statistically in a moment. And excess body weight now is estimated, it's higher in the United States, where it's the second most important risk factor, but even internationally, it's the sixth most important risk factor contributing to overall disease burden. In the United States, it's number 2, second only to cigarettes. Now, this is data from the WHO that, aging now a little bit, but still the most recent available, that compares worldwide, and this is sort of the summary column here, the number of people with a body mass index 30 or over, which is our definition of obese, and those that are less than 17, a definition of malnutrition. And you can see now that there's a ratio of about 5 to 4 between obesity and malnutrition around the world. And you can see, no surprise, that this trends based on development of the country. So in sub-Saharan Africa and other sections of Central and Southern Asia and so on, there are still substantial populations of malnutrition. But as you move even into the developing countries and the transitional countries, you see obesity dominating compared to undernutrition. Now, where are we at in the United States? This is the information from just this year. We're now up to about a third of men and women, a little bit higher in women, of individuals in the United States are defined as obesity. That means having a body mass index greater than 30. And when you combine it with overweight and obesity, it's now over 2/3. Now men are at greater risk than women, and that's because men fall a lot more into this overweight category, whereas women compared to men are a little bit higher in the obesity category. Severe obesity, which I'll also define, which is a body mass index over 40, is up to about 6% of the population. Now, one of the things that isn't realized or hasn't been well appreciated is that despite this massive epidemic in the United States and throughout the world, that in the United States it appears that the epidemic has stabilized. And that's shown here in these two curves, the two dots representing the means of the decade of 99-2000 and the more recent 2007-2008. So in the last decade, the mean body mass index and the shape of the curve has not changed very much. So that's pretty interesting, and that's true in both men and women. And so it appears that although we've had tremendous increases in the 3 or 4 prior decades, we seem to have stabilized. And although I'm not going to show you the information tonight, one can also show that the health consequences associated with obesity have also gotten a little bit smaller over the last few decades. And the reason for that, we think, is from some of the things we talked about the first week, that is the successful treatment of blood pressure, cholesterol, heart disease, and so on, that those have reduced the risks associated with obesity. And so with a stable average weight and improvements in these other conditions, the health impact of obesity statistically has actually begun to flatten out. Now, the issues in children, of course, have been very concerning. We define obesity differently in children than we do in adults. It has to do with using as the norm percentile weights that were defined about 20, 30 years ago. So you would think that only statistically, this is pretty obvious, but you would think that only 3% of people would be over this definition by definition. But in fact, this was 30 years ago, and now what we see is 12% with severe obesity, 16% with what we call obesity, and a third who are overweight. Now here too, though, there's been no increase in the last decade. So we're beginning to see some stabilization, although there are lots of pockets of disparities where this has continued to be of major concern. And here are some of them. Again, this has just been published. If you look, for example, at middle-aged women, where in whites, for example, about a third are obese. In African Americans and Latinos, it's almost half, or over half in this case. Same with teenagers. We see a big discrepancy between African Americans and Latinos and whites. And one of the most important and under-recognized associations of obesity is in the relationship with mental illness, where individuals with mental illness often are poor, may have poor access to food and other health care, and in particular take medications to control some aspects of mental illness, especially psychotic illnesses, which are highly associated with weight gain. So we're up to almost 80% of those with mental illness being associated with overweight or obesity. It's worth noting that this is also the epidemic or a population in which cigarette use is also very, very high. In general, there's an inverse relationship between obesity and cigarette use. That is, individuals who are heavy rarely smoke, and individuals who are very thin smoke at a higher rate. But that's not the case with mental illness, where the rates are so high in both of these risk factors that they live together. All right, so I've been throwing around these terms quite a bit already, so why don't we define them a little bit more precisely. In the United States, underweight is less than 18.5. I showed you 17 as the WHO definition. Normal is 18.5 to 25, very wide range of normal. And then we go into what we call overweight, 25 to 30, and then anything over 30 constitutes obesity. We like to call it class 1 or class 2 or class 3. And extreme obesity, class 3, is that when the BMI is greater than 40. The BMI is the weight divided by the height square in the metric system. Why do we use this? We use it primarily because it works. That is to say, it correlates extremely well with total body fat. And remember that obesity is in excess of body fat. It's not in excess of body weight. Now, one of the take-home messages here is that the idea that some of us grew up with of an ideal body weight, where we used to look up our height on a table and pick our frame size, and we'd get a specific number that we should be. We don't think that way anymore. Rather, there's a wide range of weights at any given height, at any given gender, associated with the best health outcomes that we consider normal. But it turns out that it may be even more complicated than that. This is some information from the CDC. This was the first study that made the observation that I'm going to make, but there have been about a half a dozen others since then. So this is no longer just one study raising an interesting new question. And the place I want you to focus is right here. So just to orient you to this slide, here now are our categories of BMI. Here are the different phases of the life cycle. And if you just focus in here on the younger group first, we use as our reference group those that are so-called normal weight early or mid in life, and then compare their risk of bad things happening over the next decade or decade and a half. This happens to be death, but you could also draw similar kinds of curves for illness. And you make a couple of observations. Number one, you see that if you're very thin, you don't do so well. You have a 40% increased risk of dying in the next decade and a half. It turns out that that's largely due to cigarettes. And if you remove cigarettes from this data, this number gets pretty close to 1. So it is okay to be thin as long as you're not ill and you're not smoking. Then what we also see is if your body mass index is over 35, you have an increased risk of early death, about 2-fold. But note that it's not 4-fold. And when we talked about bad high blood pressure and bad cholesterol, that number was closer to 4-fold. And this is the number that has decreased with time. If we look back in the 70s, this number might have been 3 or 4. But it's gotten a little bit lower over time, and we don't really fully understand that, although we think it's related to our effective treatment of the obesity-related, what we call comorbidities, or other obesity-related illnesses, such as high blood pressure, cholesterol, and so on. So this is what we would call a J-shaped curve. If I was going to graph on the y-axis mortality and on the x-axis body mass index, the shape of the curve would be like this, right? That's what we call a J-shaped curve, but the J-ing here is mostly due to cigarette use. Now here's the point I wanted to show in this slide in particular, that this very interesting observation that people who are overweight do not have excess mortality. So this is really interesting. And when this came out a few years ago, everyone said, well, it's just one study, let's see what happens. But it was a really good study because it took the National Health and Nutrition Examination Survey, which we do every decade or so, put all 3 sets of data together. This is a very carefully done, what we call observational study. And so it was really good data. And like I said, since 2005, there have been another half dozen data sets that have shown basically the same thing. And so this suggests that in that J-shaped curve, right, that in fact the middle part is even, if you'll excuse the expression, wider than we thought before. That is to say that weights between 18 and 30 all seem to be associated with good outcomes in the average person. Now clearly you can be in the overweight category and have health problems that will respond to weight loss. So if you have diabetes in this category or high blood pressure in this category, then weight loss is our best treatment. So I don't mean to suggest that. But it does appear there's not a lot, if any, excess mortality from being overweight. So that's sort of interesting. Just as an aside, let's talk about what happens in the 8th decade. Now the curve is no longer that classic J shape, but rather it starts high and sort of flattens out, right? And what that suggests is that as you enter the 8th decade, it's the very low weights that are associated with the highest mortality. This would be, the quote, the frail elderly. And you can see that as you get heavier in your 70s and 80s, that obesity is no longer a risk factor for premature mortality. Now, this may be a little bit confusing because, remember, this isn't a 50-year study. This isn't exactly the same as if we took 20-year-olds and followed them till they were 80. The people who make it to this cohort at 70 are different than the people here, that in the sense that many of the people who are sickest from their obesity may already be dead and not in this cohort to represent themselves here. But the clinical point, especially for those of you who care for elderly parents, is that the diet that you should be on as a 50 or 60-year-old may not be the same diet that your 80-year-old mom or dad should be on, right? For them, you want to make sure they're not frail and thin. And so sometimes letting them liberalize their diet is just fine. And it may be associated with more muscle, more protection around their hips for hip fractures, greater bone mineral density, and so on. So, take-home point here is primarily that what's new is that being overweight may not be as bad for our health as we thought. All right, I want to move next now and talk about the relationship between exercise and body mass index, or what I'm going to call fitness. And this is an older slide, and I'll show you a more recent one in a second, but I love this study because it was so clean and really taught me something new a decade ago that has been very useful. And if you just look at this lower part of the slide here, what these authors did was they took a very large group of men, middle age, and put them on a treadmill. They measured their body mass, put them on a treadmill, measured their fitness, and saw what happened over a decade and a half. And again, our reference point will be those who are normal weight and fit. And by fit, in this case, they use very sophisticated exercise physiologic definitions, measuring oxygen capacity and so on. In clinical terms, fit here means being able to walk about a 3 or 3.5 or maybe 4 miles per hour for about an hour, talk while you're doing it, and wake up the next morning and do it again, and the day after that and do it again. So that's sort of what I'm talking about fit in this category here, or doing pretty well on an exercise treadmill. And what they showed, which was not new, was that those who were not fit did worse than those who were fit. No surprise there. We've known for decades before 1999 that a sedentary lifestyle was bad for your health. They also showed again that being obese was bad for your health, and the risk of dying was 3-fold higher. Remember, this is now an older study, and so remember I showed you it was 1.8. Remember I said how it used to be higher, and it's sort of shrinking with time. But that's not the point of the slide. The point of this slide is this number right here. That is to say that those individuals who are obese, but despite their obesity were able to achieve fitness, did fine. And this is where the phrase fitness trumps fatness comes from. And it's not a slam dunk. Not all the evidence supports this conclusively. But this particular group, large group of men, suggests that here, that being obese and fit led to better health outcomes than being normal weight if you weren't fit. Now, not all the studies show this relationship, but all the studies do show this relationship. That is to say, that if you are overweight or obese, being fit is associated with better outcomes than not being fit. And so from a clinical or personal standpoint, that's the useful point. So when I see a patient who's coming to see us because they're overweight, whether I've made the diagnosis or they're seeking specific care, the first thing I say to them is I change the subject and I don't talk about their weight. And the first phrase is, I want you to be as fit as you can possibly be at the weight you're currently at. And that should be everyone's goal. Now, this is a similar, analogous study in women, and it's not quite as clean. Instead of putting people on a treadmill, they took questionnaires of physical activity. But it's the same basic idea of trying to quantify people who were active a lot and those that weren't active a lot, and sort of correlating with that fit and not fit. And again showed similar data, although not quite as clean. But you can see that once again, those that was body mass index is over 30, those that were physically active a lot did better than those that were not. Now in this case, this group here, the heavy but fit, did not do better than the thin not fit, but they're pretty close. So here you couldn't say fitness trumps fatness, but you can certainly say that if you're overweight or obese, that being physically active or being fit improves health outcomes. I don't know if you can appreciate this cartoon. So just another word about exercise and obesity. You know, we see a lot of people who come to the office and say, Doc, you know, I got religion, you know, I knew I was having trouble with my health and my weight, so I joined the gym, and I've been going twice a week, and I have a personal trainer, I'm working out, and I've been walking more, and feeling good, but I'm not losing any weight. And the answer to that is, and the reason for that is because exercise is not an effective weight loss strategy. Okay? So I'll come back to all the good things that exercise is, but what it is not is an effective way to lose weight. And the easiest way to see that is this bullet here. These are experiments. This is RCT stands for randomized controlled trial, so this is a large number of studies put together. Diet with exercise versus diet alone. Those who got the diet had 1 kilogram more weight loss, 2 pounds more at the end of the study. So exercise is not effective, and these are people usually on supervised exercise programs. Some of these studies, they were given free machines for their home, trainers and the like, and it just is not associated with a lot of weight loss. There's a little bit of a dose effect. The more you exercise, you get a little bit more. And for those of you who have watched The Biggest Loser or other shows, you can see that you obviously can achieve a certain amount of exercise where you sort of override this data. But this speaks to the kind of exercise that most of us would try to achieve, and I'll define that precisely in a moment, for good health. And it does achieve good health, but it does not achieve weight loss. I've already showed you, though, it makes you live longer. It improves your blood sugar if you have diabetes, your blood fats if you have cholesterol problem, your blood pressure if you have high blood pressure. So it does all the right things, though, even if you don't lose weight. So exercise is good. It's just not much of an initial cause of weight loss. Now, I've taken out I'm going to talk now about diet. So that was exercise. Now I'm going to go quickly to diet. And I have about slides from about a dozen studies, which I'm only going to show you one of, that basically make the point that on a low-calorie diet, it doesn't matter what the composition of the diet is in order to achieve weight loss. If you can achieve, if you can achieve an energy deficit, so if you need this many calories a day to break even, and you eat this many, you will lose weight. And it turns out that it doesn't matter that much if you're on a low-carbohydrate diet, a high-carbohydrate diet, a low-fat diet, a high-fat diet, a high-protein diet, and so on. That all of those work about the same. And there are now a couple of dozen studies that show this. There were studies, if we gave this lecture about a decade ago, and I asked a bunch of doctors what they thought of, say, the Atkins diet or the Stillman diet or the Drinking Man's diet, all of which were well-known low-carbohydrate diets, people would be fearful of those. But the current studies would show that diets like that, not those brand names per se, but diets designed that way with good healthy foods, but designed to be low in carbohydrate and a bit higher as a percent in fat or protein, are associated with at least as much weight loss and maybe more, and no adverse effects in terms of blood cholesterol, blood pressure, or anything else. So we now think the low carbohydrate diet is safe and effective, and in some patients it may be more effective. And I think I took out that slide, but I'll show you. I'll come back to that again. This was a new study, a little bigger than some of the others. They put patients in 4 different groups, and what you see here on either side of these slashes are the fat, protein, and carbohydrates in the diet. Remember, there are only 4 ways you get calories out of food: fat, carbohydrates, protein, and alcohol. So these are people who are not on alcohol. So now we're down to 3. And you can see that they could mix up the what we call so-called macronutrient composition of the diet, keeping the amount of calories the same. So calories are constant, and now they're manipulating how you get to that amount of calories. And generally, all these people lost some weight, roughly around 7% of their starting weight. So if you weigh 200, you can expect to lose about 15 pounds in about 6 months. That's what almost all the studies show. And good if you're coming to a university-type weight management or a good weight management program. It's not what you achieve by yourself, but if you're going to an intense intervention at a serious program. And there were the same amount that lost more in all these diets. And the point was that whether you restricted protein a little, restricted fat a little, or restricted carbohydrates a little, it didn't really matter. And all of these had the same amounts, the same distribution of responses. And it turned out that they had a group program that attendance at the group, or what we would call medically, adherence to the diet, was what predicted success. Didn't matter if you were on the Zone diet, the Atkins diet, the Weight Watchers diet, or the Ornish diet, all the same, as long as you were adherent to the diet. If you weren't adherent, didn't matter what diet you were on. So diets do work. They work in limited fashion. The reason they work is by achieving an energy deficit. So you can figure out, many people need about 2,000 calories a day to break even, maintain their current weight. If you eat 15, that's 500 down a day. For a week, that's 3,500 down a week. Turns out a pound of fat is 3,500 calories in a bomb calorimeter, and so you lose a pound of fat per week. And that's the basic principle that any dietitian will design for you as a strategy on a rational, what we call low-calorie diet. So it turns out you can experiment with the low-carbohydrate diets if you want. The South Beach diet, the New Atkins diet, there are many, many others. You don't have to use bacon and steak with fat and béarnaise sauce and stuff, and like the old stereotypic Atkins diets. But nonetheless, you can eat a lower carbohydrate diet and then add back healthy carbohydrates as the diet progresses. Now, there are some new studies that are not widely published yet, but as you look at some of these kind of studies and begin to dissect them out a little bit, what we're beginning to see is that in patients who are normal metabolically, normal blood pressure, normal blood cholesterol, normal blood sugar, don't have diabetes, in those patients, any diet works fine, low carb, high carb. In the patients who have insulin resistance, that is pre-diabetes, or a cholesterol, certain kinds of cholesterol or blood pressure problems, there is some early data to suggest that they may do better with a low carbohydrate diet. So the take-home message here is that any diet is fine, that a low carbohydrate diet is as safe as a high carbohydrate diet, and that there may be a subset of patients, it may be though half the population, so a big subset of patients, who will do better on a low carbohydrate diet than a high carbohydrate diet. So I tend to favor more of what I call a healthy low carbohydrate diet as a reasonable way to get people going. Now, I'm not going to say, when I get to diabetes later, I'm not going to say a lot about diet because it's basically the same as this issue, which is that calories trump macronutrients. That is to say, if you have obesity and diabetes together, a low-calorie diet is the way to go, and it doesn't matter how you get there, as long as you don't do stuff that's really silly. And that in some patients like that, or maybe many patients like that, a lower carbohydrate diet is particularly rational. And if you're going to eat carbohydrates at all, that you want them to be as complex carbohydrates as possible. So certainly no simple, no sucrose, high fructose corn syrup, simple synthetic sugars, or naturally occurring sugars, except as they occur in fruit or vegetables. Okay, fed up with how her diet is going, Charlene takes a more serious aim at her target weight. Okay, so just a word or two about some other strategies with diet. One of them is called the very low-calorie diet, which is the VLCD. And those are diets that are 800 calories a day. So remember I told you need 2,000 on average to break even. If you eat 1,500, you lose a pound a week. So if you eat 1,000, you lose 2 pounds a week, if everything goes silky smooth. And in fact, that's what the studies show. So if we put people on 800 or 1,000 calories a day, and this usually has to be done with prepackaged meals, so bars and shakes and soups and cereals and things like that. But people lose in the short term twice as much weight. So instead of losing in 7.5, or in this case, almost 10% of your weight on the low-calorie diet, now you're losing twice as much. In the longer term, now getting out to 2 years, and it just depends how long you follow these out, the weights come close together. So a very low-calorie diet is not a particularly important, efficacious way to get weight off long-term compared to a lower-calorie diet. They both appear to work the same. And the way this is typically done is you start on if the goal is to use a very low-calorie diet, what we do is we start on a low-calorie diet. That is, we start people on that 1,200 to 1,400 calories a day, make sure they know how to do that. Then we put them on the very strict diet, the 800 or 1,000 calories, for 3 to 6 months, depending on how long they can stand it. Their weight goes down twice as fast, and then we transition them back to what's going to be their maintenance diet of a 1,200 to 1,400 calorie a day diet again. And so we always start off with that because people can't learn how to eat that maintenance diet while they're on the very low-calorie diet, so we have to teach them that at the beginning. But it's worth noting that since this works better in the short term, it's fun to think about those kind of clinical circumstances where short-term weight loss may add value to someone. And so, for example, if the orthopedist says, I'll give you 2 new knees, but you have to lose 50 pounds, or the back surgeon says something similar, or the transplant surgeon says, you know, I'd love to give you a new kidney or a new liver, but you're too big for our list. Or maybe even before you're about to go into bariatric surgery. Those are the kind of, or if you have diabetes and you're on 100 units of insulin and going nowhere and just gaining more and more weight, those are the kind of circumstances where this more radical approach may be effective. We also use it, of course, in patients who, for whatever reason, don't want to have surgery. And so I'll show you the numbers later on. But if a regular diet is about 7%, 8% of your weight loss initially, and the very low-calorie diet is double, about 15%, surgery is about double again, about 30%. But surgery, bad things happen to some people, and some people don't want to have surgery. So we see this as sort of an intermediate option for high-risk patients who don't, or for whatever reason, don't want to have surgery. And like I said, we often use it before the surgery as well. Now, even though, in summary, the data would suggest that this is not effective long-term, in my anecdotal experience doing this for 25 years, the only people I personally have cared for that have been able to lose 75, 100 pounds and keep it off long-term without surgery are people who started with a very low-calorie diet. Because when you're 100 pounds overweight, it's very hard to do that on a 1,400 calorie a day diet. So the more dramatic approaches are occasionally effective. It's only about 10–20% of patients who have that kind of dramatic success, but they exist. All right, let me move next to weight maintenance. I've now been talking about weight loss. Now I'm going to talk about weight maintenance. So two separate things. Get the weight off, keep it off. And if you want to read more about this, the best place to look is something called the National Weight Control Registry. This is a place where people who have been overweight and lost the weight and kept it off sign up and keep track of it. And so these are people who have lost about 70 pounds and kept it off for 5 years. So these are your successful dieters, your successful weight losers. And the interesting question is, what have they done that other people haven't done? Now, it's not that generalizable. It's mostly Caucasian women. But it is worth noting that some of them were heavy as a kid and some of them had parents who were overweight. So the myth that these kind of people can't lose weight is not correct. So they have a lot of features, these folks, but there are three that really stand out. Number one, they exercise a ton. They exercise works out to about an hour of moderate intensity per day. Now, many of you have heard that the Institute of Medicine and the federal government and other experts are recommending that all Americans exercise an hour a day as a strategy to prevent weight gain. Ironically, that recommendation comes from this data. Now, that's a little bit of a stretch because this is a little bit different group of people. These are people who lost the weight and kept it off. Nonetheless, they were able to keep it off, or being associated with keeping it off, was an hour a day of moderate intensity, and this works out to about 2,500 or 3,000 calories per week. So that, brisk walking, that 3–3.5 miles per hour brisk walk that you would do and be able to talk through it. And the equivalent, an elliptical machine, this is cardiovascular exercise, swimming, treadmills, skiing machines, so on, bicycling, as opposed to jogging or riding a bicycle really fast or cross-country skiing on a slight uphill. Those would be more intense exercise. If you exercise intensely, say if you jog, instead of, you get about the same benefit here as in about 30–35 minutes. So you get about twice as much benefit from more intense exercise. Secondly, they eat a diet which is low in calories. In this older studies, it was suggested that it was low in fat, but in fact, the more recent versions of this show that it can be either low in fat or low in carbs. It doesn't matter. What matters is that it's low in calories. So this is a 1,400 calorie day diet for weight maintenance. Okay? So this is one of the most important points to make tonight. That is to say, the calories that you require to lose weight initially becomes the amount of calories you need to eat long term to keep it off. And there are many reasons for that, physiologic and so on, that we can discuss if you'd like. But the point is that it's a very low number and that you need to know that going in. Because if you go back to eating 2,000 calories a day after you diet, you're going to gain all the weight right back. And the third thing is that they monitor their weight. So it doesn't mean they go to the bathroom weigh themselves every time they go to the bathroom. But it does mean they have a plan, and they either weigh themselves once a day or once a week, keep track of it, and when they start to bump up, they intensify their program. So the take-home message here is that weight loss can be kept off, but it requires a tremendous strategy that's at least as intense as the strategy to get it off to begin with. And it must include what we would normally consider high levels of physical activity, fairly severe calorie restriction, as well as monitoring to do so. And this is why it's so hard to do this. All right, a few words about medication and surgery, and then I'm going to switch to diabetes. All right, we don't tend to use a lot of medications for weight loss in San Francisco, but there are many other communities in the Bay Area, and certainly in Southern California and elsewhere around the country, particularly the Southeast, where they do. And it's one of these things that really has sort of developed around regional practice style, I think. But my view is that these medicines are somewhat effective. They're not that much more effective than diet alone. Remember, I said diet alone leads to about 7–9% in big studies of weight loss. These commonly used medicines are in roughly the same range, maybe a little bit less. And they're expensive, and they have the side effects of medications, so they don't add much for me. Moreover, when people stop taking the medications, unless they have a plan for weight maintenance, then they're just going to gain the weight back. So we don't yet have a strategy for this class of medicines like the strategy we have for blood pressure, cholesterol, and diabetes. For those three conditions, we've learned to accept chronic lifelong medications because we have long-term studies that show chronic lifelong medications save lives for some of the drugs, especially the ones I talked about the first week for cholesterol and blood pressure. We'll talk about diabetes in a moment. But for these drugs, we don't. These drugs were approved primarily based on the ability for them to be associated with weight loss, period. Not weight loss and then less heart attacks, just weight loss. So we don't really know that much about what happened to these drugs if you stay on them long term. This is not meant to be a comparison of one versus another. The three most commonly ones available now in the United States are phentermine, sibutramine, and orlistat. This is Xenical or Ali in the supermarket over the counter. This is Meridia, and this has many trade names. Phentermine tends to be the cheapest. It's the oldest, but it's only approved for use for 2 to 3 months, whereas these are approved for 2 years. And orlistat is now available at half this dose over the counter. The problem is they all have lots of side effects. They're somewhat expensive, and like I said, the long-term effectiveness is weak. And part of the logic for that, I think, comes from this cartoon, which is meant to describe what is currently known about control of appetite and energy balance. And I like to joke that when any good medical student knows that when the professor shows any slide with this many arrows, it's usually because they don't really know what's going on. And at least it suggests, if that's not the case, that this is awfully complex, that we evolved to preserve our appetite, and we have many redundant biological pathways to preserve appetite. And so the take-home message here is you can imagine if you block any one of these, something else is going to kick in and overcompensate. And so it's highly unlikely, in my opinion, that any single drug, unless we really find it right at the right level where it's the final common denominator, but it's highly unlikely that any single drug is going to treat appetite or change energy expenditure in a way that chronically treats obesity. So I don't think single drug therapy for obesity is going to have much future. On the other hand, we don't treat blood pressure with a single drug most of the time either, or diabetes or diabetes. We do cholesterol most of the time, but not blood pressure and diabetes. So maybe the issue is just need combinations of drugs. And so the next great thing is going to be combinations of drugs marketed by industry as weight loss drugs. We don't know if these are going to be approved yet. They're mostly in phase 2, some phase 2 trials. But they're likely to be approved because the criteria for approval is only that they're associated with short-term weight loss, not long-term prevention of heart attacks and strokes. And they're mostly made up of drugs, at least these first 3, that are already approved. So bupropion is Wellbutrin that we use for smoking cessation and depression. So that's a pretty safe, effective drug. Zonisamide is an anti-epileptic that is associated with some weight loss in some people. And so that is one combination. Bupropion here with naltrexone, which inhibits urges associated with alcohol and opioids. And so the thinking is that maybe it will also help with the urges associated with binge eating and the pleasure that people get from eating. And again, our old friend phentermine, and here another anti-epileptic drug. So these will probably get approved and probably be available. But personally, I think I'll continue to be a slow adopter in these medicines because we just don't know of their long-term safety and effectiveness. And this is another class of drugs that will have that I'm less confident will be approved. But it's back to the selective serotonin receptor agonist. sort of like the dexfenfluramine that you may remember from a decade or two ago, which was associated with a lot of side effects and taken off the market. So we'll have to follow this one carefully. But I'm pretty sure some combination of these will be approved in the next couple of years. I'll just say a few words about surgery. Al's still hanging in there. All right, weight loss surgery is something that has been quite important and dramatic over the last decade. There are three ways generally to do this. You can make the stomach smaller so that after you eat you feel full. And they make it pretty small, about 30 cc's, so the size of a big surgeon's thumb. And there are a variety of ways to do that. I'll show you some cartoons in a moment. The two most common are the vertical banded gastroplasty and the adjustable laparoscopic banding. Secondly, you can make a patient, you can change the anatomy of the GI tract so that people malabsorb their foods. Then they will get what we call malabsorption syndrome, which may include nutrients in the stools, fatty diarrhea, things like that. And so we don't tend to like these operations because it changes the physiology more dramatically. And at least this one here led to a lot of long-term side effects. There are local physicians that are strong advocates of these procedures, though. We just don't have as much long-term published experience. But patients sort of like them because you can eat in a less restricted way because you don't get that early fullness that you get when the stomach is really small. And the most popular one, that's still 80% of the bariatric surgery in the United States, is what's called the Roux-en-Y gastric bypass. You're basically making a small stomach pouch, and then you have the opportunity to create some malabsorption depending on how long you make the limb. And this is what it looks like. So this is the vertical banded gastroplasty, and they have some newer versions of this now, where they just create a small pouch with a very small stomach in here. You can do this by putting a band around the stomach and a port under the skin, which allows you to inflate the band to various intensities, and that's called the adjustable lap band because it's done laparoscopically. This is no incision is made here, so people like this one in theory, but it turns out it doesn't work as well and has more long-term side effects. But in the short term, it's less side effects. But you have to come in often to have this adjusted and so on. And the one that's most commonly done in the United States, this is very commonly done in Australia and other places, but the results here haven't been as positive. But the common one is here is the Roux-en-Y gastric bypass. So again, you have the stomach is now resected, and you have a small pouch. This is the esophagus. The food comes down the esophagus, goes into this relatively small residual stomach, and that makes people feel full. So they eat small feedings throughout the day. The food then passes through this now part of the intestine, which is brought up to meet the stomach here. But you're doing it, this is now intestine that used to start down here. Remember, this was the normal path of the food: esophagus, main part of the stomach, duodenum, jejunum, down into the rest of the intestine. Now we're bringing up a limb of the jejunum and connecting it up to the stomach. So you have this bypass path that's no longer coming in contact with food, and that can create some malabsorption. And so the surgeons can make that longer or shorter, depending on how much malabsorption they want to create. But this primarily works, we think, as a restrictive procedure also. But these are the most common procedures done in the United States. With any of these surgeries, the things we care about get better. Blood sugar gets better, blood fats, blood pressure, sleep apnea. So weight loss associated with surgery is effective. It makes people feel better, and most of the conditions get better. But there are some side effects, and I won't read these all, that can occur in the early days after an operation. So it's a pretty long list. Things that can occur later after a surgery. In addition, now there have been fairly good comparisons of these different procedures, and without going into too much surgical detail, the comparison of the Roux-en-Y with the lap band favors the Roux-en-Y gastric bypass. So this review, which was done here by non-surgeons, ended up favoring the Roux-en-Y gastric bypass, and that's the primary procedure that's done in the United States still. How do people do in terms of outcomes? About the 30-day overall mortality is 0.3%. So 3 out of 1,000 patients will die in 30 days, so 1 out of 300. It's a little bit more and inflated by the patients who get the old-fashioned open Roux-en-Y. So if you're so big that you need to have a complete incision, the outcome is less good. But if they can do the operation through a laparoscope, a flexible telescope, well, it's not flexible, but a telescope with multiple small incisions in the stomach, then those patients do better. You can see initially the lap band is safer, but has more longer-term complications as that band erodes into the stomach, and there are other complications. And if you looked at more serious side effects like death, pulmonary embolus, or blood clots, the need to have a second operation, or the need to stay in the hospital, it's about 4%. So it's not nothing. So this is not that different than other elective surgeries. So sometimes the surgeons say, well, it's not any worse than a cholecystectomy, a gallbladder surgery. Well, it is, depending on who you are. But the more important thing is that a lot of these operations work about, in most patients, but there's a subset of patients, about 5%, who have a really tough road with this. And like I said, 1 out of 300 will die. So these are tough decisions. Who does worse? The people who have had blood clots before, the people with sleep apnea, the people who are in less good shape before they start, and the people who are bigger when they start. So unfortunately, not unfortunately, but just as an observation, what's been happening is that the surgeons tend to pick more and more of the younger, healthier patients to do the operation. But in fact, they're not necessarily the ones who need it the most. This was a study that was recently published that was interesting because it showed what they did was before they did the surgery, they put people on a weight loss program fairly intensively to see what would happen if they lost weight before the operation. And the patients who lost weight before the operation did much better, had lower complication rates than those who did not lose weight before the operation. So that's our practice, is we strongly get to try to get people to lose weight before bariatric surgery. So bariatric surgery works. I think it's really hard to know for whom and how often, but it is an option. It does save lives, but the number of people you have to operate on to save one life is pretty high, and it's almost 1,000 operations a year. There is some short-term morbidity and mortality. So in summary, let me just leave you with this. The main goals of management for weight are: be as fit as you can possibly be at your current weight, prevent further weight gain, and again, this is where that fairly intensive exercise is useful, whether you're doing that having lost the weight to get there or not. And then for selected patients, there are a variety of strategies to try to get people to lose weight, starting with exercise, behavior modification, diet, in some cases medications, some cases more dramatic diets, and in a few patients, surgery. Eat less and exercise more. That's the most ridiculous fad diet I've heard of yet, but it's still the case. All right. Let me pause and see if there are any questions or comments. If anyone wants to stand up. I'm unfamiliar with that, but I think the Snickers would suggest our collective skepticism. So, I'm showing you, the best data about the best products, and none of them are associated with sustained weight loss. So the likelihood that something is available of that sort is 0 to none. There are dozens and dozens and dozens of supplements that are heavily marketed for weight loss. Some of them have chemicals that are now banned, like ephedra or other stimulants. Others have actual pharmaceutical products in them. There are some that are contaminated with mercury and lead and so forth. and others just have a lot of caffeine and other sort of stimulant kind of products, and none of them are associated with long-term or even medium-term weight loss. So most of those are a hustle. It depends how many calories a day you're eating. Remember, proteins have 4 calories per gram, so it's the same as eating carbohydrate. So it just depends on how that is adding up to your daily energy balance. So think of it as you have a budget per day of the amount of calories you can eat to maintain your current weight. And whether you fill that up with protein, fat, carbohydrate, doesn't matter. If you hit the budget, you'll stay constant. If you go under the budget, you'll lose weight. And if you go over the budget, you'll gain weight. So if you took in a lot of protein shakes, and that was an extra 500 calories a day, you would gain weight. You do not grow new muscle just by changing your diet. You grow new muscle by stressing muscle, that is by exercise, resistance training. So B vitamins are, of course, necessary for the metabolism of proteins, and therefore the association, I think, in marketeers' minds, yes, you need B vitamins in order to metabolize protein. That's basic biochemistry. But they work as coenzymes. I don't know if you know what that means, but they help facilitate various chemical reactions. And once you have enough of it, you're done. So you need a certain amount of, say, a vitamin to make the enzyme work. But then if you triple the amount of that vitamin, it doesn't work 3 times as fast because it's already done. So that's why almost every study that has ever taken a vitamin out of a food and put it into a pill to show some beneficial health effect has been a negative study. So if you want to grow muscle, then you go to the gym and eat a good diet. You don't need protein shakes. Most of us get plenty of protein in a mixed diet. If you want to lose weight, you can use, quote, protein shakes, although I'm not sure exactly what you mean, but you can eat a diet which is higher in protein than you would normally take, as long as the overall composition of the diet was lower in calories than what you need, if that makes sense. So you want to use 30 calories per kilogram of what your ideal weight sort of would be, right? And the reason for that is that excess fat does not contribute as much to your daily energy requirements. It's mostly your lean body mass that contributes. So if someone your height would normally weigh 70 kilograms, and you're a man, and you're exercising a lot, or exercising an average amount, then 2,100 calories, 30 times 70 would be about right. If you weighed 90 kilograms instead of 70, but you were that same height, it might work out to 23 or 24, but it wouldn't be 27, right? So it's about a third of the difference. So I usually stick with the lower number, and roughly 30 calories per kilogram, but that's a rough estimate. The truth of the matter is, for the purposes of prescribing diets, unless you're really big or really small, 2,000 for most bigger size, the half of you on that, or the bigger half, 2,000 is not a bad guess, and the smaller half, somewhat less than that's not a bad guess. And that's why it doesn't matter very much, because what really matters, it doesn't really matter if your energy deficit is 600 calories a day or 500. As long as you have a deficit, it's going in the right direction, it's all good. So it doesn't really matter that much. What matters so much more is the adherence to the diet than exactly how big the energy deficit was. The exception to that is people who are small, particularly women, and people who are older. Because they're at the extremes of people who are short and older and have less muscle mass may only need 1,400, 1,200 calories a day to break even. And then it's really, really hard to go on a diet to create an energy deficit. So that's where it gets a little bit tricky. But in general, 1,800 to 2,200 is not a bad guess for most people. All right, let me move on because I want to talk about diabetes. Okay, now let me begin with the observation that diabetes and this epidemic we're in with diabetes is not localized to the United States. And so, although we have a ton of diabetics in the United States, and I'll break that down for you in a moment, many, many other parts of the world do as well. And so the prevalence is actually greater, not as a percent, but just because there are so many people in India and China, their absolute number of cases is even higher than ours. As a percent, there are some surprises. We're up to about 8% in the United States, but there are some other countries, this is the South Pacific, the Middle East, most people don't think of as a place with very high diabetes prevalences. Other places, places like India, where there's pockets of malnutrition, again, we're now seeing overnutrition and diabetes. So there's a lot of diabetes around. We're at about 8% of the population. And this is how it breaks down. The vast majority have what we call type 2 diabetes. Type 1 is the so-called juvenile onset diabetes. It's an immune disease. Those kids need to be on insulin. They get a lot of complications to their eyes and their kidneys and their nervous system. It's a very serious issue, but it's a very different issue for the most part to the more typical or more prevalent type 2 diabetes, which is associated in most cases with obesity. There are a lot of these people out there who are not yet diagnosed, so that's sort of interesting. Probably millions of people. It may not be quite this high anymore, but there are millions of people who don't know they have diabetes because they're in the early stages and don't have a lot of symptoms. And then there are a whole bunch of other people who have prediabetes, or what we call the metabolic syndrome. And they're the people who are not unlike the people I talked about the first week, who also have high blood pressure and cholesterol, blood triglyceride disorders. And those tend to go together. Central obesity, hypertension, a high blood triglyceride, a low blood HDL, and a high blood sugar. Not quite high enough to be called diabetes, but high enough to be called impaired fasting glucose, or IFG. You can also make this diagnosis with a glucose tolerance test. So this is an important condition that we don't use drugs for the most part, but very intensive diet and exercise. And it's been shown that if you use diet and exercise appropriately in these patients, you can slow the progression to diabetes substantially. Now, just this January, there's some new recommendations of how to care for patients with diabetes. The take-home message of this slide is that we recommend not routine screening of all people for diabetes, but all people over 45. But younger people should also be tested for diabetes if they're overweight or obese and have any of these other risk factors. So at least 2/3 of the people, if not more, with all these conditions, when coming to the office, should be checked with a fasting blood sugar for diabetes. So at least 2/3, maybe 80% of patients would meet one of these criteria. That's a good question. No one knows. You know, that's a good. The question was how often, and you can actually ask that to any topic in this course, and not have a scientifically based answer. But typically, for individuals over 45, we would do it annually. For people with any of these conditions, if they were going in the wrong direction, we might do it annually, or we might do it every 2 to 3 years. And here's a very simple-minded relationship of the syndrome that we really think of as the prediabetes is insulin resistance. What happens is the combination of obesity and a sedentary lifestyle, which themselves feed on each other, causes insulin resistance. That is, the insulin doesn't work as well in the fat cells and the muscle cells. It causes the pancreas to overcompensate, lead to high levels of insulin, and then eventually the pancreas wears out and develops type 2 diabetes. The inability of the pancreas, of the insulin, to control the blood sugar caused from our food. And that, of course, is associated with cardiovascular disease. And again, the definitions we use are primarily a fasting plasma glucose or fasting blood glucose 126 or greater. About a decade ago, not quite, we said 140. So we've lowered this, so it's a little bit cheating. So part of the reason the prevalence went up was that we lowered the threshold. But we've sort of done that with we've done that with almost everything, as we've learned that even early stages of diabetes and pre-diabetes are associated with increased risk of heart disease. We don't typically use the hemoglobin A1C as a screening test. We use it rather to follow patients who have diabetes. But the new recommendations do show with newer generations of this test that it correlates very well with the blood glucose. And so either of these can be used. Sometimes the insurance doesn't cover this test, though, depending if you don't yet have a diagnosis of diabetes. So I still primarily use the fasting glucose. When it's over 126 twice, then we make the diagnosis of diabetes and then start using the confirmatory test of a hemoglobin A1C. I won't say that much about aspirin. We talked about this a little bit the first week, but just to re-emphasize the point I made the first week, we were talking in the context of prevention of heart disease in general, but it's also true of prevention of heart disease and stroke in patients with diabetes, which is to say that aspirin is effective, but aspirin, as benign as we think it is, does have harms as well. And if you remember that scale I showed the first slide or so at the beginning, the first talk, we're always balancing risks and benefits. And so the risks roughly stay the same, independent of the benefit. But the benefit varies depending on the things we talked about that first week. So if the benefit, if your risk of something is low, then making it lower doesn't help that much. If the risk of something is high, then lowering it helps a lot. And so we save aspirin for those whose risk of having heart disease is relatively high. And again, it's that 10% number using the Framingham scale that we talked about the first week. So typically this turns out to be men over 50 and women over 60 with diabetes. It used to be that we use aspirin for much lower age limits, but we're becoming a little bit more conservative with aspirin. We like to treat blood pressure, cholesterol, and tobacco use very aggressively in patients with diabetes. I won't spend any more time on this since we talked about it in so much detail the first week, but our goals for these are a little bit more aggressive than for patients without diabetes, or at least they're either as aggressive or a little bit more aggressive. One recent study that questioned this was a study that just came out this year that compared a blood pressure. Usually we try to get the blood pressure in average patients with high blood pressure that we talk to less than 140. But for diabetes, the earliest slide said less than 130. So this was a study that tried to compare 120, less than 120, with less than 140. And it turned out that being less than 120, that is, that more aggressive treatment, didn't help as much as we thought. So there were some less strokes, but in terms of the primary study design, which was a composite of all these things together, there was no benefit of a more aggressive approach. So I'm not sure how this will translate, whether it will change our guidelines or not. Right now, our official guideline is less than 130 in diabetics, less than 140 in non-diabetics. But this may suggest that maybe we don't have to go to less than 130. Now, let me review 3 studies. Maybe I'll try to skip over these a little bit quickly because they roughly show the same thing. But there has been a debate that has gone on at UCSF, interestingly, as well as the rest of the planet, for as long as I've been here, which is a long time. I came here in 1974, and we had 2 internationally known diabetologists here. One was Peter Forsham, who himself had diabetes, and had lived to a very ripe, old, successful age, believing that tight control of his blood sugar was what led to his success. And we had another internationally known, lovely diabetologist named Marvin Sipperstein at the VA, who felt that it had nothing to do with blood sugar, that blood sugar control, that it just didn't matter. It had to do with other vascular factors that predicted who was going to get heart attacks with diabetes and who wasn't. And this is true. This is, what, 35 years ago. And there were major debates, and you were in different camps around here. And this debate has gone on for 35 years, and it continues today. But we do, in the last 3 years, have 3 new studies that have tried to address this issue. And here's the background. The background is we know for sure that tight control of blood sugar in type 1 diabetics, those kids with lots of injections, prevents eye problems, kidney problems, nerve problems. We do not know for sure, although there's a trend, that ultimately it also prevents heart problems in those kids. But the evidence there is not perfect. The question has been, what about in the adults, the other 90% of diabetics? Does tight control matter as much? Because type 2 diabetics don't get as much eye disease, kidney disease, and nerve disease. They get it, but not as much. It's not as devastating as it is in juvenile onset diabetes. And the main killer there, some kidney disease, but kidney is only 3 to 5%. The main killer is heart disease and stroke. And so the question is, does all this messing around with blood sugar really lead to better outcomes? That is, less heart disease and stroke. And so that's what these studies were designed to answer. It's led to some interesting changes in the way we think about this. So this one was called the ADVANCE study. It was a very large number of patients. It was intensive versus standard blood sugar control. In this case, the hemoglobin A1C was typically less than 6 or so is normal. 5.5. 6.5, remember, is diabetes. So the aggressive people, the people who believed in the tight control, wanted to normalize the hemoglobin A1C, and the control group was looser, was 7.3. And then we looked at a variety of heart disease kind of outcomes. And basically what it showed, that there was a little bit of an improvement in the overall picture with the tighter control, about 2%, but it all came from microvascular events, which themselves aren't that common. And again, when we looked at the things we really cared about, which was death from all causes, death from heart disease, and other macrovascular events like stroke and so on, there was no differences. So this study was unable to prove that tight control was more effective. So no big deal. Argument continues. 2 camps, whatever. But then this study came out. And the other study was a European study. We tend to be very biased in this country. We like American studies. This was an American study. It was funded by the National Institute of Health. Same design, a lot of patients. And what they did was they did 3 things at the same time. They compared blood pressure. I already showed you that results. They compared different 2 drugs versus 1 drug for cholesterol, and I showed you those results last time, showing that it didn't matter to have 2, that the statins alone were as good as the statins plus fibrates. But the arm we're going to talk about today was to compare tight control, a hemoglobin A1C of less than 6, with between 7 and 8. And everyone thought that 6 was going to be better, and you know where I'm going. Not only was 6 not better, but 6 was worse. So they were able to achieve this difference, but there was no difference in the primary events. But when we looked at mortality, there was a 22% increase risk of dying if you were in this intensive group. So not only did this suggest that tight control wasn't better, but it raised the question of maybe tight control was worse. And in fact, when you calculated, you needed to treat 333 people this way to kill 1. So the number needed to kill was 333. So the NIH actually stopped this study early because they were worried. So we ended up with 1 study that was no difference, 1 study that shows harm. And then there was a 3rd study that the VA did, which basically the same idea. Again, they compared 8.4 to 6.9. and basically, again, no significant reduction in heart disease. So the take-home message was there was no consistent evidence that tight glycemic control reduces the risk of cardiovascular disease. So for today, this year, ciprostine wins another round, we still don't have proof that this reduces heart disease. There were some subsets that I skipped over quickly that may benefit those who are with new onset diabetes and those with less evidence of existing heart disease. But again, that's not the average patient we see in the office. Typically we see patients who have had diabetes for a long time and already have evidence of heart disease. And again, there's strong evidence to support decreases in microvascular disease, but there are side effects to the more intensive regimens and no benefit on mortality and maybe some negative effects. So the current guidelines are that rather than, so the way this has gone, when I was a medical student or a resident, we didn't have hemoglobin A1C, but if we did, the goal would have been something like, keep it less than 8. We used to say less than 200 blood sugar, because that way you wouldn't spill blood sugar in the urine, and your infection control would be okay. And then we kept getting tighter and tighter and tighter. So it was about 8 when I was a resident. It was 7 about a decade ago. Then the diabetologists and the endocrinologists kept pushing for 6.5. Some were even pushing for 6 until these recent studies. And now, this year, the Diabetic Association has pushed back a little bit and said, hold off here. We don't have to push everyone down to normal. We don't have to make everyone crazy. But let's aim for 7. You can go tighter, less than 7, for some patients, certainly juvenile onset diabetics, and for those with short duration, long life expectancy, and no evidence of heart disease. But then they also put in this quote, which is good for us doctors. It says that you actually can be even looser for those with a history of trouble with low sugar, limited life expectancy, people who already have complications, other diseases, and I love this one, and those in whom the goal is difficult to obtain. That is to say, don't make yourself and the patient crazy if it's making everyone crazy, is how I interpret this last one here. So the average patient who's well-informed and young and willing to do it, we still go for a tighter control, but we don't normalize, but we've begun to back off a little bit. In some patients, we can be looser and stay 7 to 8. I've taken out some slides to show that we've had a similar pendulum in the hospital as well. There was a couple of studies about 5 years ago that suggested that very tight control in the hospital and in the ICU also save lives, but the more recent studies has not shown that. And so that pendulum has also swung back, and so what we now do in the hospital is that we aim for 140 to 180, whereas just a few years ago we were aiming for less than 110 blood sugar. And so this is a real difference, a change in practice. Okay, I'm going to spend the rest of the time on medications. Like I said, I'm going to skip over diet because it's really the same principles as the management of overweight and obesity. We have a lot of drugs to use for diabetes, and most patients need more than one. If you switch from one drug to another, your blood sugar doesn't improve much, stays flat. But if you add a second drug to a first drug, it works good, and that's what we end up doing. So we start with one. I'll tell you which one in a moment. We add a second, and then sometimes we'll add a third or even a fourth. It's worth noting that the biggest effects, though, on your blood sugar are in the first 2 drugs, at least for the pills. Insulin is a separate conversation because insulin can be very effective at any level. But for the oral therapies, the first drugs are the most effective drugs. They will lower the hemoglobin A1C roughly by 1.5 points or so, and the other drugs about half that amount. Now, I'm not going to read all this, but it's there for you, for your reading, and it sort of lists the various classes of drugs. You can see that there's a long list, and that they all work by different actions. So it's somewhat analogous to blood pressure. and it allows us to mix and match these drugs with relative impunity, with the knowledge, however, that there are differences in cost amongst these, and I'll go through these, and side effects, and that the first two classes of drugs are more effective than the third and fourth classes of drugs. And again, I'll define that in just a moment. There are also safety issues with all of these classes, especially some of the newer drugs. And again, I'll spend a bit more time on that in just a moment. Okay, so bottom line here is we have several drugs. The oldest drugs that have been around are the biguanides. You may know it as metformin. And it's the drug we typically use as the first drug. It's the only drug on these lists that has been proven to save lives in the long term in diabetics. It also is associated with weight loss in obese diabetics rather than weight gain, and it's the only drug that does that. So we almost always start with metformin. There are some exceptions, like if you have kidney damage, and it causes some people some nausea or diarrhea, but in general, almost always the first pill. The second pill is usually what we call a sulfonylurea, and they are older ones and some medium old ones and some newer ones. They're all about the same as far as effectiveness. They all work very well with metformin. We have less information about their long-term effectiveness, but they've been around for decades and we have good confidence in them. But the truth is we don't have perfect data. But we almost always use that as the second drug. And after that, there's a debate. And the rest of the talk, I'm going to spend a little bit of time going through some of the issues related to this debate because it really serves as an interesting example of how we make decisions about what drugs to use in our society. And as all of you know, this is today's headlines, because today the FDA subcommittee debated again whether to take one of these drugs that I'm going to discuss in just a moment off the market, and had a split vote. Some newspapers will report today's vote as saying that 2/3 of the panel voted for, I'm talking about the drug Avandia, which is a brand name of this class of drug that I'm going to talk about in a minute. Rosiglitazone is its generic name. And so the way the panel voted, some newspapers are going to say 2/3 of panel votes to remove drug or maintain it with lots of restrictions, right? But other people are going to report the same vote count, saying 2/3 decided to keep it on the market, although there might be some restrictions. So it was almost a third, a third, a third. Just take it off, leave it on with lots of restrictions, or leave it alone more or less. And it just shows how polarized we are and how the tensions are and how we make decisions about things in medicine. But it's a really good example, and it's a classic example. We call this course the mini medical school, and this is a classic example of how we teach the medical students how to think through some of these issues. So for example, we had these two good classes of pills, the metformin and the sulfonylureas. And then the thiazolidinediones came out about a decade ago. Avandia was one of them. One has also already been taken off the market. And Actos is another common trade name, pioglitazone. And what the drug companies started doing about half decade or 7 or 8 years ago was try to design studies that looked like they were designed well, but were specifically constructed to show the kind of outcomes that favored the use of the drug by not necessarily studying what we really cared about. So for example, one study that got a lot of press a decade ago was, well, if we use this drug compared to metformin, you don't need to start a second drug for 3 months shorter. Well, who cared, right? I mean, that's a totally unimportant endpoint. We care about heart attacks, strokes, deaths, so on, not because everyone's going to end up on more than one drug. Or there was, we care about kidney failure, but rather than measuring kidney failure, because that would have been a long study that was expensive, they measured a secondary measure of something that might lead to kidney failure. And again, made a lot about it. Or they measured some measure of atherosclerosis that doesn't really correlate all that well with what happens in terms of heart attacks. So these were sort of slimy, if you will, don't quote me, ways to show superiority of a class of drugs over the existing therapy, rather than the way you would really like to do it, and which health reform will now pay for, which is actually give a group of patients the standard therapy, give another group of patients the new therapy, randomize them, follow them for 5 years, and see what happens. Then we know, right? Not this kind of, quick and dirty nonsense. But then this study came out in the New England Journal about 3 years ago, and it looked at all the data that they could find about this drug, rosiglitazone or Avandia, and basically showed that if you took Avandia compared to standard therapy, you had a 43% increased risk of heart attack and a 64% risk of death. Now, what you're reading about this week is that this was based on the studies that he could find. And it turns out the company was actually suppressing some of this data. So there was even more. So it was sort of like the Vioxx scandal of a few years ago. One of the other studies, so then the company did its own study and showed, well, in our study, it didn't look so bad. Except even in their own study, there was twice as much congestive heart failure, which is the leading cause of hospitalization in the elderly. So there was really nothing to suggest that this class of drugs was superior, which was the original argument, and maybe some evidence that it was inferior. Now, there was this other drug, pioglitazone, and interestingly, although they also tried to show that it was superior, and I won't bore you with the details of the way they did that, but in general, they were this drug, for some reason, didn't show to be worse. So this is the pioglitazone, this is the sugar pills, and at least they weren't killing people with this drug. There wasn't increased heart attacks. And then, since then, I think I've taken the slide out, but there have since been some comparisons of the two drugs. And then finally, this study just came out, it was published last month, June 28th, and it's sort of what rekindled a lot of this conversation, because there was a direct analysis by the FDA of Medicare patients, so these are real people, comparing rosiglitazone, Avandia, with pioglitazone. And any place where the number is greater than 1 means there was more harm associated with rosiglitazone. And you can see a trend towards more heart attacks, more strokes, heart failure, death, and the two combined. So this is what rekindled the debate and led to at least the third of the panel voting today to take this drug off. My own view, if I was on that panel to begin with, I'm not sure I would have approved the drug, but certainly we all stopped using it, at least those of us in primary care for the most part, stopped using it back about 3 years ago when that study started coming out suggesting that it may be worse. And luckily we had pioglitazone, so we could still keep people on the class of drugs if we wanted to, although most of us weren't that keen on this class of drugs anyway. We were pretty convinced that it was at least the third best class of drugs, and we had two good ones to go before it. So, in summary, the thiazolidine diones are one of the more controversial classes of drugs. It's what's in the news today. My prediction is that Avandia will either be taken off the market or, well, I'm not going out on a limb here. It'll either be taken off on the market or there'll be much more severe restrictions in terms of warnings and so on. But I think for my own practice, it's not a drug that I need to use. I should have said at the beginning, I am going to be talking about a lot of drugs, and do not take any of this as medical advice for yourself. If you're on your drug and you want to call your doctor to ask questions, that's fine. We want to engage patients, but do not change your therapy based on what you learned tonight, but feel free to ask questions. All right, I'm going to move to some other issues and then swing back to some more drugs at the end. One of the things that comes up a lot is this issue of pills not working anymore. And so we often will say to patients, you failed oral therapy, it's time to go to insulin. And it turns out that that's a misconception. That it's not that the pills have failed, but rather it's the natural progression of the disease. And that is to say that when you start off with insulin resistance, that happens before you make before there are any symptoms or the diagnosis of diabetes can be made. Then your insulin increases. So here's your baseline insulin level. And then your insulin levels overcompensates. Your pancreas works harder and harder to keep up with this need to push the blood sugar into the cells, which is what insulin does. And then eventually it fails. And after 10, 20 years, the pancreas fails and your insulin level goes down. And so what happens is that the pills stop working because the way the pills typically work is by helping secrete more insulin. And at a certain point, that's no longer possible because the pancreas is out of business. And so at that point, you get worse again and may need insulin. So it's not so much that after 10, 15 years you have failed the pills. Rather, at the beginning, people should understand that the first phase of this is with diet and lifestyle. The second phase, you continue intense diet and lifestyle as long as you can. The strip of green that continues forever. But you start metformin early on, and you may start another pill. And then at some point, you may need insulin to finish the treatment of this disease. So it's not a failure, it's not a surprise, it's just part of the natural history of diabetes, especially if weight is continuing to increase or sedentary lifestyle is continuing. And it's easy to use insulin these days. I won't go over this in great detail, but many patients can be treated with 1 shot a day at night of one of the newer insulins. And that's relatively easy to do. You don't have to check your blood sugar 4 times a day or take 4 shots a day. But there are other patients who we do add 4 shots a day. And again, I think I'll skip this to go to some of the newer stuff. But there are a variety of regimens and ways to do this. There's no one right way. But many patients end up on 4 shots a day, 1 long-acting insulin and then 3 short-acting insulins before each meal. Or you can use some pre-mixed versions of combinations of long and short that also work pretty well. Now, what's been new in the last few years has been several other new classes of drugs. And I want to introduce them, particularly this category here. These are the 4 that are currently available, I think. Exenatide, sitagliptin, saxagliptin, and liraglutide. And these are drugs that are incretin mimetics. That is, in the same way that insulin is replacing a body hormone when we give a shot, what these drugs are doing are also replacing a hormonal function that we didn't even know existed until about a decade or so ago, at least not in this context. Here's the definition of these incretins. So it's another factor. They're made in the GI tract, and they're factors that promote insulin secretion in response to nutrients. That is to say that when you give someone sugar through the vein, a certain amount of insulin is found to be released. But when you give the same amount of insulin by mouth, more insulin is released. So something is happening in the intestines, in the GI tract, to stimulate insulin that is being bypassed if you just give the insulin through the vein or under the skin. And this class of chemicals, of factors, are called the incretins. And there are 2 groups of them. There's the ones that have this direct effect, and then there's an enzyme that breaks them down, and you can also block that enzyme, and that makes the natural occurring incretin last longer. So the mechanism isn't that important, but we have these 4 new drugs that are available now to do this new effect that I never even heard of in medical school. So it's a new set of gut factors that stimulate insulin that are now, again, being heavily marketed to treat diabetes. And so this is a cartoon that shows how they work. The primary effect is that they stimulate insulin and repress the other opposing hormone, which is called glucagon. They also slow gastric emptying. They maybe inhibit appetite and so on. So these are theoretically a very attractive combination of events for a patient with diabetes. The problem is they don't work all that great. They work, and they are approved, and they are used commonly. But it's one of these classes of drugs that turns out that has been, when I talk to primary care doctors, only about 20% are using these drugs. But if you talk to diabetes specialists, about 90% are using the drugs. So there's a real split in the community about the effectiveness of these drugs. Generally, they lower the hemoglobin A1C by about 3/4 of a point. So remember, I said the metformin and the sulfonylureas were about 1.5 points. So they're about half as good as the older drugs. What got a lot of very positive press, though, was that they were associated with weight loss, especially the injectable one called Byetta or exenatide. These are not effective as weight loss drugs, but in diabetes, when used to replace insulin, they can be associated with some weight loss, even though insulin is associated with some weight gain. There are side effects, including a fair amount of nausea. And so one of the hypotheses is that the reason they cause weight loss is because people are so nauseated. The other class of drugs, the so-called DPP-4 inhibitors, also lower hemoglobin A1C by about 3/4 of a point. Forget these other bars, but this is the one I want to show you. And they also have their own side effects. But interestingly, they don't cause nausea, and therefore they don't cause weight loss. So that's sort of part of my suspicion about the weight loss thing. But I think the take-home point is that these drugs are relatively weak, and that there's now a debate in the community amongst diabetologists as well as amongst others who care for patients with diabetes about whether we should be spending more and more resources on developing new drugs that are adding bits and pieces to control versus using the drugs we have more effectively. And that's sort of where the tension is in the community. And so, and of course, these differences in drugs, let me go back one. So if you look at this cartoon, the question is, remember, this is where I showed it before with the biguanide and this stuff here. And now some people would add the thiazolidinedione and the incretins, but I'm a little reluctant to do that. I'm still sticking with this stuff in most patients, as are most generalists. And one of the reasons is cost and the issues of resources. So some of these older drugs like sulfonylureas are very inexpensive, and metformin very inexpensive, whereas some of these newer drugs you can see are much more expensive. And the newer drugs, again, much more expensive. And just for fun, I put what your local YMCA costs. So this is how it splits in the United States, actually worldwide. We have two approaches. They're both legitimate. This is not my terminology. This is from the American Diabetes Association. It's a consensus statement. And what they would call well-validated therapies typically would be diet and exercise is what they mean by intensive lifestyle here, metformin first, and then as a second drug, either starting nighttime insulin or sulfonylurea. And whichever one of those two you do second, you can do the next one next. Typically, we do metformin first and then a sulfonylurea. And then if that doesn't work, we add insulin. So that's the typical approach, the least expensive, best known way. It is associated with some weight gain, though, and so there's some interest in using some of these newer drugs. And maybe a role for the thiazolidinediones. But if you're going to use one of them, you should probably use Actos instead of Avandia, and or one of these newer drugs, but again, with less evidence to support them. But both of these approaches are available. But again, I think they represent symbolically where we want to take our priorities in drug development and clinical care. You know, should the priority be in constantly seeking new and more drugs, which add small amounts of benefit, or should the focus be on working on better use of the drugs we have, better access to care, greater social justice related to resources, and so on. And that's really what a lot of the healthcare reform debate was about. But I think this discussion of diabetes medicines is an excellent symbol of that. So to summarize this section, what we've learned this last 2 years now is that tight glycemic control is not as effective as we had hoped in preventing heart disease that diabetics primarily die from. There are a lot of new drugs available. They all have some side effects, but few with the kind of hard outcome data that we really care about. Blood sugar control is more important early in the disease, so definitely in children, teenagers, young adults. And that some of the things, the mom and apple pie, is to remember to take care of the basics, which is to take care of your blood pressure and your cholesterol in conjunction with your blood sugar if you have diabetes. So with that, I think I'll stop, and thank you for your patience and take any questions. Thank you very much. Yeah. So I don't know if everyone heard the question is the fact that it seems disturbing that these drugs get approved and based on drug company studies and not all the data gets published, and it takes 10 years of post-use surveillance to really find out the truth. Yes, that is how our drug approval system is set up. Remember, I think that a lot of this grew out of the AIDS epidemic and cancer research and this tremendous demand for new drugs, right? So that's really the context, right? That we really we believe in drugs, right? We believe in molecules. And if we could just find that one more molecule, we're going to beat this thing, right? That's the theory of all these diseases. And it continues to be the theory with cancer and HIV and so on. And so we've lowered the bar in terms of allowing, and the drug companies have applied a lot of pressure, and sectors of our government, who support free enterprise and lack of regulation have supported that sort of approach. And then through certain parts of our recent history, there have been less and less resources devoted to the FDA. And in fact, the FDA has been funded by the drug companies, and with lots of back and forth, get a job here, get a job there, get a job here kind of stuff. And that's part of what's changing with healthcare reform is re-strengthening the FDA, putting professionals back in, putting more resources in monitoring of safety. Not so much raising the bar about drug approval. That hasn't changed much yet. But we're beginning, we're certainly putting more attention in post-surveillance marketing. And what clinical effectiveness research is, of which there are billions of dollars in the Healthcare Reform Act, is to do exactly what you're saying is let's not approve these drugs until we actually have head-to-head comparisons that really show that one is better than the other. And I think that's where everyone wants to go, but it's very expensive. It takes a long period of time. And it requires a government or taxpayer investment because the only alternative is the drug companies themselves. And then you get poorly designed studies and in the worst cases suppressed data and so on. I think we're not going to have as much suppressed data in the future. I think they got caught, and there's probably still some out there, but I don't think there's going to be a whole lot of new stuff. That would be pretty reckless. But of course, we might have said that about the stock market a year or two ago. So, right, that's true. Right. Other thoughts? All right. Well, I appreciate your endurance. I know it's late, and I'll stay up here for any additional questions.